Hello, my name is Kathleen McKean, and today I'll be presenting on my DNP project titled Cranial Positional Deformities in the NICU, Implementing Change into Practice. I would like to thank all those who helped me throughout this program, and especially my DNP chair, Dr. Gail Pitroff, my second reader, Dr. Rita Wunderlich, and my community member, Dr. Stacey Hayes. My project's aim was to determine if the implementation of tummy time education decreased the rates of cranial positional deformities in the neonatal intensive care unit, or NICU, at a children's hospital located in the Midwest region of the United States. In the Scholarly Project Sites Department, there is no policy or practice guideline regarding the prevention of cranial positional deformities. The American Academy of Pediatrics implemented the Back to Sleep campaign to reduce the incidence of sudden infant death syndrome, or SIDS. This campaign aimed to reduce the sudden and unexpected death of infants by reducing the risk of sleep-related suffocation. Recent literature confirms that the publication of this recommendation to put infants to sleep on their backs or supine position has led to a decrease in the rates of SIDS. The unintended consequence of this movement is that the rates of cranial positional deformities, or CPD, have significantly increased because infants are participating in less awake prone positioning or tummy time. According to a systematic review of 16 studies examining the effect of tummy time on health and developmental outcomes, tummy time has a positive association with an infant's total development. The positive associations that were found include improved gross and fine motor development, demonstrated by the achievement of rolling, crawling, and earlier attainment of unsupported sitting. They also include a decrease in BMI and a preventative measure against brachycephaly, flattening of the back of the skull, and plagiocephaly, flattening on one side of the skull. The neonatal intensive care unit is very unique in that it provides care to the extremely vulnerable population of newborn infants, often born too early or with complex medical conditions that require intensive care. The implementation of education to NICU caregivers and families on the importance of tummy time is fundamental in decreasing the rates of cranial positional deformities. This project illustrates the impact of cranial positional deformities and the importance of implementing an evidence-based quality improvement initiative into routine NICU care. From conducting a thorough literature review, I developed three main themes on the topic of cranial positional deformities in newborn infants. Contributing factors to cranial positional deformities, positive effects of tummy time, and negative effects of cranial positional deformities. The first theme is the contributing factors to cranial positional deformities. The prevalence of cranial positional deformities has soared within the last several decades. This issue is multifaceted, and several different factors contribute to play a role in the development of these skull deformities in infants. A nationwide campaign for the prevention of SIDS developed by the American Academy of Pediatrics in 1992 called for supine positioning for sleep. In other words, it advised parents to place their infants on their backs to prevent sleep-related deaths by suffocation. A reduction in sleep-related deaths of 40% in the United States was seen following this campaign. However, an increase in CPD rates was noted to be approximately 30%. Other countries began implementing their own guidelines following the U.S. campaign, with the Canadian Pediatric Society also recommending placing an infant supine to sleep in 1999. Spending a prolonged period of time in one position or too similar a position can have consequences. The skull is easily moldable in the first few months of life, as the cranial sutures have not yet fused so that the cranial bones can pass through the birth canal. Because the sutures have not fused, the application of external forces or pressure can lead to deformities. For example, placing a baby on its back or supine position can lead to flattening of the occiput. Infants do not possess the ability to move in one's environment with ease and without restriction. This lack of independent mobility is a contributing factor to cranial positional deformities. Infants are completely dependent on their caregivers for the first few months of life to change their position, as they are not able to roll independently. Infants are spending less and less time in prone positioning with the new recommendations for supine positioning for sleep and a lack of education provided to parents on the importance of tummy time. Infants with first-time parents are more likely to present with CPD, as they may be overly cautious and hesitant about positioning on the floor for tummy time. There's a lack of education for new mothers on tummy time. Only half of postpartum mothers and a quarter of mothers at a 2-month checkup receive information regarding infant positioning during awake time. Parents reported infant was not tolerant to being placed in the prone position, so they did not adhere to recommendations from their providers. There's not enough awareness among parents for deformational cranial molding defects, oftentimes mild cases that could go undiagnosed and untreated. This lack of education on the benefits of tummy time and uncertainty of infant tolerance due to fussiness can contribute to the development of CPD. While most newborns go home within the first few days of life, infants admitted to the NICU earn stays of weeks to months depending on their gestational age at birth and other factors. Parents of NICU patients tend to be more timid and nervous to participate in their child's care due to their small size, the monitors, and the cords attached to ensure hemodynamic stability. The NICU population is mostly comprised of premature infants, who are at an increased risk for CPD as risk increases as the gestational age at birth decreases. Preterm infants have a softer skull, underdeveloped organ systems, high head-to-weight ratio, and muscle weakness, thus their ability to move their head is poor and they require longer sleep periods. The second theme is the positive effects of tummy time. CPD rates have risen, but there are modest interventions that can be performed in both the inpatient and outpatient setting for NICU patients and at home with supervision. The intervention for the Scholar study was the implementation of tummy time education for NICU caregivers. The World Health Organization recommends 30 minutes of tummy time over a 24-hour period for optimum healthy growth and development. Several positive effects of tummy time have been examined and include earlier achievement of milestones, lower BMI, muscle development, and less development of cranial positional deformities. Increased prone playtime has been associated with earlier achievement of many developmental milestones, including earlier milestones such as sitting, lifting head, crawling, and pulling to stand. In a study examining motor development and postural control in supine, prone, sitting, and standing positions in infants at 6 months of age, those who participated in more tummy time scored higher in all categories. Tummy time also provides infants a physical challenge, as developing the muscles of the neck and back can only be attained at this age from practicing stabilization in different positions. Prone positioning provides that challenge and allows infants to begin developing head control. Tummy time can be practiced in any safe location supervised by an adult who has had education regarding safe tummy time practices. If infants can only tolerate short periods of time in the prone position, doing several short sessions and gradually increasing the amount of time in each session can help to eventually meet those recommended guidelines. The third theme is the negative effects of cranial positional deformities. Positional head-shape deformities have been a growing issue among babies for the last 30 years and cause functional problems as well as cosmetic and psychological consequences. CPD has been associated with motor developmental delays, cognitive developmental delays, changes in facial features, and shifting of the eyes and ears. Plagiocephaly, a form of CPD, can present with an asymmetric head shape, misaligned ears, and facial asymmetry. In a longitudinal study following infants with and without plagiocephaly throughout 36 months of life, the children with history of plagiocephaly received lower developmental scores. Motor developmental delays have been the most common negative effect of positional deformities. Helmets are a popular corrective intervention for plagiocephaly. However, they are associated with adverse effects such as skin irritation and pain. These helmets often come at a high price, on average almost $2,000, often only covered partially by insurance. This corrective therapy is not affordable for all families, and some infants with moderate to severe defects require this correction or suffer physical and psychological consequences. A literature critique was conducted to provide this scholar with insights into the source's strengths, weaknesses, gaps, and limitations. Some strengths that were noted from these studies are approval from international review boards, IRBs, or other committee or university organizations that have strict standards for conducting research on participants, and most of the studies had large sample sizes, and data was collected in at least 8 different countries, showing the global impact this topic has on the infant population. Some weaknesses of the studies reviewed were that most were observational in design, which limits the significance of the findings compared to something for extensive, such as randomized control trials. It could also be argued that several of the studies had a high selection and performance bias, which reduces the study's ability to accurately represent different socioeconomic and cultural groups. A gap noted from this literature review is the issue of most studies looking at the association between positional deformities not being able to determine if the delay is the cause or the consequence of the skull deformity. This is troublesome as it calls into question any question to prove causation, only association. Some limitations include a possible publication bias because it is unknown whether or not certain studies were not publicized because of no results. and that in different traditions regarding baby care may contribute to varying cranial metrics among regions and countries. The concepts and definitions important for understanding the content of this project are cranial positional defect, gestational age, and prematurity. Cranial positional defect is a condition in which specific areas of the infant's head develop abnormally flat in shape and appearance. Gestational age is the period of time between conception and birth. Prematurity is babies born before 37 weeks of pregnancy. Subcategories of moderate to late preterm, 32 to 37 weeks, very preterm, 28 to 32 weeks, and extremely premature, less than 28 weeks of gestation. The framework that best fits the scholar's phenomenon of interest in this project is Casey's model of nursing, developed in 1988 by Ann Casey specifically for child health nursing. This model focuses on the importance of the nurse working in partnership with their patient and their family, with the philosophy that the best people to care for a child are their families with the assistance and guidance of healthcare professionals. A Level 4 neonatal intensive care unit is very unique in that it provides care to the extremely vulnerable population of newborn infants, often born too early or with medically complex needs that require intensive care. This scholars project was the implementation of tummy time education, as well as the general education on the importance of tummy time to NICU caregivers and families that hope to decrease the rates of CPD. Parents of NICU patients tend to be timid and nervous to participate in their child's care, especially in the beginning of their infant stay. Properly educating these parents and their NICU caregivers on the importance of tummy time and how to accomplish this specifically in the NICU can decrease the incidence of CPD. In addition, it empowered parents and gave them the confidence they needed to be able to participate in their child's care and to bond with their infant. The key elements of Casey's model are the child, family, health, environment, and the nurse. Adopting a partnership approach to care as the nurse with the patient and their family is a way to build trust and improve their experience. In this scholars project, the role of NICU families plays a large part, as they were provided the education to practice this intervention, tummy time, as they can continue to do so even after discharge, now that they are armed with the resources to do so. This project is a quality improvement project. The data for this project was extracted from electronic medical records, EMRs, of NICU infants receiving care at the author's hospital. The author recorded the minimum necessary data to accomplish the goals for this project on the data collection sheets. All potential patient identifiers were removed and not collected for this project. All infants receiving care in the chosen NICUs at the facility during the period from March 1st, 2023 and August 31st, 2023 were reviewed for a retrospective chart review. 24 EMRs of those patients identified as having CPD were reviewed for this project. The age of participants was 1 day old to 7 months old, and all genders were included. The data abstracted from the EMRs from the patients receiving care in the NICU from March 1st to August 31st, 2023. The inclusion criteria was as follows. The EMR must have had documentation that the infant was receiving care in the chosen NICU from March 1st, 2023 to August 31st, 2023. And the EMR had to have documentation that the infant was 1 day old to 14 months old. The exclusion criteria was as follows. If the EMR had documentation that the infant was not receiving care in the chosen NICUs from March 1st, 2023 to August 31st, 2023, and the EMR was closed and no data was retrieved. And if the EMR had documentation that the infant was older than 14 months, the EMR was closed and no data was obtained. After Institutional Review Board approval was obtained for Maryville University, the data collection process began by obtaining a list of patients that received care in the chosen NICUs from March 1st, 2023 to May 31st, 2023. The lead therapist provided the researcher with the list of patients identified as having cranial positional deformities from March 1st to May 31st. The researcher determined the rate of the cranial positional deformities by comparing the infants identified with CPT with the total number of infants receiving care in the NICU during that specified time frame. This served as the pre-implementation rate. Then, NICU nursing staff and caregivers received tummy time education by online distribution of PowerPoint to ensure that nurses from both shifts had equal access to the information, and in-person follow-up for one-on-one engagement with the material and an opportunity for questions and feedback. Weekly reminders of the project start date and educational materials were sent to NICU nursing staff. dispersed via email beginning in May 2023, and the implementation of the Tummy Time Education Project went live on June 1st. The post-implementation data collection process began by obtaining a list of patients that received care in the chosen NICUs from June 1st, 2023 to August 31st, 2023. The lead therapist provided the researcher with the list of patients identified with CPD from June 1st, 2023 to August 31st, 2023. The researcher determined the rate of cranial positional deformities by comparing this list identified with CPD with the total number of infants receiving care during that specified time frame. This served as the post-implementation CPD rate. A data collection sheet was created by this scholar, and the information gathered from the electronic medical records was de-identified and imported into this sheet. If identified NICU patients in which a cranial positional deformity was present, the estimated gestational age at birth, the birth weight, and the type of cranial positional deformity present. Of the 24 charts, 15 were from the pre-implementation group collected from March 1st to May 31st, 2023, and 9 were from the post-implementation group collected from June 1st to August 31st, 2023. The estimated gestational age of the infants was categorized according to the World Health Organization definition of prematurity. Infants born less than 28 weeks are extremely premature. Infants born between 28 and 32 weeks are very preterm. Infants born between 32 and 37 weeks are late preterm, and beyond 37 weeks is considered full term. The extremely preterm accounted for 25%, or 6 of the patients. The very preterm accounted for 16.7%, or 4 of the patients. The late preterm accounted for 54.1%, 13 of the patients. The full term accounted for 4.2%, 1 of the patients. Data for this quality improvement project was analyzed using a lower tail z-test for the difference of two proportions, a specialized form of chi-square. This test was chosen for its ability to compare the pre-implementation rate to the post-implementation rate to determine if true change occurred. It was determined before data collection with the coordination of Maryville University statistician that a power of 0.8 and a sample size of 154 participants would be needed to reach a statistical significance of 0.5. There were 159 patients admitted during the pre-implementation period, and 15 charts were identified for CPD. This demonstrated a cranial positional deformity rate of 9.4%. There were 169 patients admitted during the post-implementation period, and 9 charts were identified with CPD. This demonstrated a cranial positional deformity rate of 5.3%. Despite this resulting decrease in CPD, the data analysis revealed no significant difference in the CPD when NICU caregivers were provided education on tummy time. The power calculation was 0.4146, considered low to medium in strength. The interval low limit was negative 0.0977, and the interval upper limit was 0.0156. And because 0 included within that interval, there is no significant evidence to show a change. A limitation of this project is the ICU environment often being fast-paced and decisions on priority having to be made when patients are in a critical state and when staffing does not always allow for the time needed to provide additional developmental care. Another possible limitation of this study was the time constraint, as the census fluctuates throughout the year and as possible CPD rates would also fluctuate. Another limitation of this project was the large number of nurses needed to educate and staffing issues leading to non-core NICU staff working in the NICU. This NICU requires anywhere from 45 to 65 nurses to care for infants on any given shift and employs hundreds of nurses of varying commitment statuses, full-time, part-time, PRN, etc. In a time of high census, staffing requirements are met with contract staff and nurses from other units. These nurses would not have received that tummy time education and therefore were unreliable in providing the recommended tummy time intervention. Implementing this project alone made it difficult to reach all those nurses. The literature review for this project showed limited implementation of tummy time practices in intensive care unit environments. However, significant support for the positive effect of tummy time and adverse effects of cranial positional deformities was identified. A need to address cranial positional deformities is supported by the increase of CPD of approximately 30% following the AAP's Back to Sleep campaign. This project focused on NICU patients due to their vulnerability to developing CPD and the scholars' access to a large unit with the support of education and research departments. Premature infants have a softer skull, higher head-to-weight ratio, and muscle weakness, limiting their ability to move their heads and prevent pressure-related changes of head shape. Achieving the World Health Organization recommendation for 30 minutes of tummy time each day for the optimal health and growth and development of these infants is not possible in the NICU without the help of NICU nursing staff and caregivers, as therapy staff are limited in their session allowances with each patient. This supported the development of tummy time education to increase the amount of tummy time these infants are receiving on a daily basis. The pre-implementation rate of cranial positional deformities was 9.4%, while the post-implementation rate was 5.3%. While this rate of change is statistically insignificant, it validated the presence of CPD in the vulnerable population of NICU patients, and this decrease supports a need for tummy time education to NICU caregivers. The results supported the anticipated outcome. However, the limitations identified may have contributed to the lack of statistical significance. To improve outcomes in the future, it would be important to address the identified limitations and barriers. To address the limitation of time constraint, this scholar would continue gathering the rates of CPD for a more extended time period, more than 3 months conducted in this project. A longer time frame would also allow for periodic evaluation of the process and to review feedback from staff to potentially improve their workflow by implementing tummy time education. This scholar would also assemble a committee of tummy time champions to address the barrier of reaching all staff assigned to NICU outside of NICU core staff. This committee would consist of NICU nursing staff who have had specialized education and training in tummy time practices who could help to ensure those nurses understand the implementation of tummy time while working shifts in the NICU. Introducing tummy time education to NICU nursing staff and parents decreased the rates of cranial positional deformities in the NICU. This decrease, seen in post-implementation rate of CPD in NICU patients of 4.1%, supports a decrease in the number of infants requiring corrective intervention and decrease the costs associated with therapies, also improving the fine and gross developmental motor incomes of these patients. The decrease in CPD rates seen in this study supports policy development of tummy time practice in this patient population. An implication for practice of neonatal intensive care units would be implementing tummy time policy to prevent the development of cranial positional deformities in NICU patients. Another goal of this project was to provide the tools to NICU caregivers to continue this practice after discharge, to improve those infants' physical and developmental outcomes. In conclusion, cranial positional deformities in neonatal intensive care unit patients are associated with functional problems, cosmetic consequences, and psychological consequences. CPD has been associated with motor developmental delays, cognitive developmental delays, and changes in facial features. Decreasing the rates of CPD decreases the costs associated with corrective therapies. It provides caregivers the skills to continue practicing tummy time at home to further enhance their infant's growth and development. This quality improvement project demonstrated a decrease in the rate of CPD with the implementation of tummy time education. Although statistically insignificant, this will help support the development of new standardized tummy time policy in NICUs. This concludes my presentation. Please reach out with any questions to my Maryville student email listed here, and thank you for your time.